I want to talk today about some tips that we've learned for doing covered intubations. One of the difficult things people find is the plastic tends to stick to the tube. The other difficult thing is if you use the garbage bag because it's crinkled, it's difficult to see through the bag. So to fix the first problem, I've used some 12mm aluminium tube and I've bent it to make a frame to put the plastic on. To solve the crinkling problem, we've been using surgical drapes. To reduce contamination at the distal end of the circuit, before the patient came into the theatre, I make a small hole in the drape. I pass the end of the HME through the hole. And I connect the CO2 sampling line and the circuit. It can be difficult to orientate the drape after you've taken it off, so I'm going to put some tape on the top right hand corner. To reduce the contamination of the patient's bed linen, I'm going to use an induction pillow, which I'm going to place under the sheet. And I'm going to place a bluey under the patient's head. As an alternative to using nasal cannula and a surgical mask, I'm planning to use a Hudson mask on low flow after the surgery. I'm going to place this before induction and then move it off to the side. I'm going to do a modified rapid sequence induction. After a long pre-oxygenation, I'm going to check with my assistant, are you ready? I'm now going to induce the patient. When the patient's asleep, I'm going to position the intubation drape and clip it with bulldog clips. If this patient were likely to desaturate rapidly, I would place the frame on before induction. I'm now ready to intubate. I'm going to connect the tube to the circuit. My assistant will support the tube in the circuit. Blow the cuff up. I'm going to take off my outer layer of gloves. And test ventilate. When I'm happy that the tube is in the right spot, I will secure the tube. I'll now place a bite block. If you are unlucky enough to need to perform resuscitation, you can do it with the drape over the face to reduce aerosol. Be careful about other lights being on in the operating theatre because some of them will cause a lot of glare on the plastic. At the end of the case, remove the eye tapes under the drape. To suction, it's easiest if you make a small nick in the drapes, pass the sucker through, and then you can suction the patient. When the patient is ready to extubate, I'll deflate the cuff, and I'll remove the tube. I'm going to keep the tube wrapped in plastic and disconnect the circuit to provide them some oxygen. I'm going to leave this plastic cover over the face until I'm convinced that they're not going to cough. When I believe it's safe, I'm going to place the Hudson mask over the patient's face. I'm then going to disconnect my filter and wrap the plastic and the sucker and the tube in the drape and dispose them directly in contaminated waste. I'm going to transfer the patient to their own bed with their own pillow, and when I do so, I'll remove the blue sheet and also place this in the contaminated waste. Using an intubation frame and a clear surgical drape, I find I can perform a direct laryngoscopy almost as easily as I would normally. I hope these tips are useful to you.